Today on Primary Care, childhood trauma, a risk factor for heart disease, cancer, and other leading causes of death.
I didn't think that I was going to be 40 years old. I didn't think I was going to be 25, let alone 21.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care. We know that traumatic experiences like sexual abuse or a car accident can trigger both mental and physical health issues in adults. But what about the trauma that's experienced in childhood? What effect does that have on an adult's health? A study by the Kaiser Foundation found that as the number of traumatic experiences in a child's life increases, so does the likelihood of risk factors for diseases like heart disease, cancer, and chronic lung disease later on in life. Joining us today to talk about childhood trauma and the effect it has on the health of children and adults is Dr. Mark Sloane. Dr. Sloane is a board-certified pediatrician with specialized training in adolescent behavioral medicine. He is the owner and medical director of the Center for Behavioral Pediatrics and is a founding member of the Children's Trauma Assessment Center in Kalamazoo, Michigan. Dr. Sloane is considered an expert in the diagnosis and treatment of learning, attention, and behavioral disorders in children and adolescents, and possibly adults also. Dr. Sloane, welcome to the show. So glad to have you on Primary Care.
Thanks, Dr. Lonnie.
Good. Listen, most people don't even recognize that this topic is an issue sometimes. Tell us, what is childhood trauma?
Well, that's a great question. I still get people asking me that if I'm talking about a traumatic brain injury or some sort of physical trauma, when we're really talking about the impact of psychological trauma, emotional trauma on development and behavior. So and the definitions have been a struggle with some of the scientists. What does it mean? We know that one of the things that it's an overwhelming response to something adverse, and 9/11 was a great example of that. That was probably the only time that we've had the country exposed to the same trauma at the same time because of social media and all the coverage. And we were able to see people's reaction to that, and people that struggled going in were going to struggle after it happened. And so this overwhelming response to an adverse event that makes the child feel helpless, or the adult feel the helplessness is a big part of that. And one of the things we try to prevent is it turning into a learned helplessness, where it's internalized and everything looks scary to the child. And that's what we're trying to prevent, that the child's seeing danger around every corner. Things that are normally not dangerous look like that to them. And so what we've learned is a buffering family system, extended family system, can make all the difference, and that's something that we don't have as much now as we used to. But so I guess that's a good start on.
So an event, a action of some sort occurring in childhood or during childhood can actually last for a long period of time.
We struggle with the event versus the impact, because the system has been set for years on the event. In fact, our director at Western at CTAC, Jim Henry, did his PhD on what happens to kids when they disclose sexual abuse. And what they told him, every one of them said to him, 95 kids said, I was asked this: are you sure? Are you sure it happened? If you're sure, then bad things are going to happen to that person. So we have to make sure that you're sure. And so they had to tell their story over and over again. And nobody was looking at the impact of that on the child. And so we still say this to kids all the time. We don't even mean it, but didn't that happen to you when you were young? Weren't you 2 when they took you away from your parents? And you're 10 now. And so the implication is, you should get over that. But the impact is a ripple effect, and we know that, especially if it's not dealt with. And some people that survive childhood adversity into adulthood often are, smart people. They have resiliency. They do amazingly well, but if we don't honor their stories, then that can have this kind of ongoing impact all the way into adult.
So what are some of the symptoms of childhood trauma during the pediatric years?
So that's a great question because they overlap with all sorts of things that we see all the time. And I'm a behavioral pediatrician. I started out in general peds for 15 or 20 years, and I saw a lot of my own patients struggling with behavior issues, school performance, impulsive behavior, getting in trouble. I kind of like those kind of kids, maybe because of my background. I always said normal kids are boring was my motto. You know, I liked the kids in trouble because I spent most of my 7th grade year in the office, I think, in middle school. So we see a lot of attentional issues, especially kids that are spacey and distractible. That's one of the things that I tell teachers all the time. The spacey and distractible kid doesn't necessarily have ADHD. He might have something like child trauma. That's in his, and he's going to a place in his head. Sometimes explosiveness and anger can do that. And what we see a lot of times is just a defiance and oppositionality can be looked at as a willfulness thing. We constantly struggle with this, the willfulness paradigm. And, you know, because I said so, I'm the teacher, you need to mind. You know, you need to mind and you need to do what we're supposed to do. And so often when kids can't do that, they can't manage their emotions, and it comes out as oppositional and defiant, that is often a traumatic etiology, even though it looks like it's a choice. So we really try to get people to look at trauma from a behavior from a different lens, the trauma lens. And this, not why did you do that, but what happened to you? That's the question to ask.
So some of these things might be considered just everyday behavior going through the course of a day, but they do have negative implications in terms of how it impresses a child's behavior then and possibly in the future. Maybe some of these things are connected to adult diseases that we struggle with without ever making, as a primary care doctor, we're not making the connection to childhood instances or experiences that they've gone through.
Well, that's a great question, a great lead question, because the ACEs study that Vince Felitti, who I've actually met and worked with who's now 82, he's an internist, but he was working with obese patients, morbidly and dying of their obesity. And they found that the people that were successful in his program would gain the weight back. What he found was those folks had basically all been sexually abused as kids.
Wow.
And so he submitted it to CDC, and they basically said, well, we don't believe this. You need a good study. This study isn't good. So he put Dr. Felitti together with Robert Anda, who's an epidemiologist, and they did a study with 17,000 people. And so when they looked at them, they asked them 10 questions. 5 of them were the standard abuse questions: emotional abuse, sexual abuse, physical abuse, etc. And then 5 were family dysfunction questions. Did you live with someone that was incarcerated? Are you from a divorced family? Did anybody in your family take IV drugs? So the ACE score ended up being 0 to 10. And what they found in the study, only 30% of the sample had a 0. And the higher you went, the more it impacted physical illness as an adult. And that was a major breakthrough.
Hold that thought, Dr.
Really
Sloan,
interesting.
because we want to get back to that ACE studies. Yeah. We're up against a break. Next on Primary Care, you will meet a man who once believed violence was a normal part of life.
All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become 1 in a million.
Since his earliest childhood memory, violence has been a part of 40-year-old Ray Winans' life. He remembers growing up in a household where family members were both victims and predators of violence. It was only 2 years ago, after speaking with a friend, that Ray realized violence is not a normal part of life.
Growing up in the city of Detroit, like I said, violence was normal for me. I grew up in a household where my mother, she dated drug dealers. My father was a former drug dealer. He was murdered when I was 9. My uncles, my aunts, they were all involved in that lifestyle as well. And so violence I wasn't protected from violence in the sense of when I hear my family members talking about some of the shootouts or some of the people that they had had to use violence against, right? And in other scenarios where folks can victimize my family. And so I was trained at a young age, especially around the things of violence, to retaliate, right? And so that was just the way I was trained. And so growing up in that environment, I learned very fast how to survive, right? And so part of my survival was selling drugs. I moved out my mom's home when I was 14 years old. I just decided to leave, right? Because my mother decided she wanted to get her life in order. At this time, I had been exposed to a lot, lost family, cousin was murdered when I was 11 years old. One of my friends was murdered in front of me when I was 14 years old. By the time I was 15 years old, I took someone's life, right? Prior to that, it was things that I was out in the community doing that was adding to this issue of violence, right? And so with being a perpetrator of violence from that age 14 to 15, a lot of people wasn't surprised that I had been charged with murder. At 15 years old, it was kind of like, hey, you know what, you're going down that road of self-destruction. At the age 15, I was tried as an adult. However, I was sentenced as a juvenile. And so being sentenced as a juvenile, I was mandated to the courts, warded to the court to the age 21, 15 years old. So that was a 6-year sentence. I soon realized that, hey, you know what? This is no different from the streets. This is no different from the community. And so I found myself mixing and mingling with all the guys who had been driving violence in the community, know a few people, right? And so I was just pretty much having fun and learning how to manipulate the system, the program. And so going through that, I worked the program and I was out by the time I was 19, right? And so coming home at the age 19, still with a 15-year-old mindset, back into the same community. Actually with a bigger responsibility to the community in the sense of selling drugs, driving violence, because people were looking forward to me to come home. And man, my position as a leader from a negative lens, right? And so the guys who were older, they started giving me different nicknames. So my name was no longer Red, right? It was like, hey man, he a little killer. That's Little Killer Red, right? And so these type of things added to my childlike mindset. And so I was back in that cycle. So by the time I turned 20, I was again getting caught up in that lifestyle. I was faced and charged with kidnapping, obstruction of justice, and drugs. I had ended up going to federal prison this time, so I did state and federal time. I didn't know about trauma then. I didn't know about the adverse childhood experiences or mental illness either. The greatest tool that I have in my toolbox right now is this tool called ACEs, the Adverse Childhood Experiences. And so I received a master certification in ACEs. I went through this process, and so learning about ACEs is 10 questions, and it's based off your earliest childhood memories, experience up until the age 18. And so some of them is household neglect, emotional and sexual abuse, physical abuse, right? Parents being separated and things like that. And so when I tested myself for my ACEs score, my ACE score was an 8 out of 10. I soon realized that, hey, you know what? The way that we've been educated, the way that we've been raised was all wrong. Because I was brought up in a toxic, in a trauma-induced environment. It was so normal that I didn't recognize it as trauma. I recognized this is my way of, this is the lifestyle that we're living, and anything outside of this is not normal. I didn't think that I was gonna be 40 years old. I didn't think I was gonna be 25, let alone 21. Because it was told to me that I wasn't gonna make it, and I believed the people who told me that. So I'm like, at this level in the game, I might as well just go on and live. So I'm not surviving no more, I'm actually living. And living has been so much better than surviving. Living is a whole lot better than surviving.
Dr. Sloan, at the end of the video, we just saw Ray Ryan say that living is far better than surviving. Sounds like a lot of childhood trauma there.
Oh my gosh. You know, I met Ray in April, and I haven't stopped thinking about him since, quite frankly. He had this enormous impact on me because he said something, we were on a panel together at Authority Health and at a conference, and I just couldn't get over what he said, that when he started working with the boys in his neighborhood, he said, I started hearing the boys talking about PTSD and trauma now as a conversation. He said, that's when I knew I was making a dent, because I never had anybody helping me do that. And I was just overwhelmed by the quantity of trauma he was around, and the numbers of murdered people he knew, and just things that I had no exposure to when I was younger. But I really just, his passion to help was so powerful. And now he's an ACEs trainer. He went through the program that Michigan is doing now, and now he's got language even more than he had when I met him 6 months ago. I can't get over how important that is for people to change the conversation and talk about trauma and that it's not something that happens to other people. It's just insidious and happening to all of us.
Ray's ACE score was 8 out of 10.
8, and the 6 also is 20 years less living, 20 years. And that's based on chronic immune dysfunction.
So I as a internist, I could relate this to other studies that say, if your blood sugar is not controlled, you knock this many years off your life. If your high blood pressure,
exactly.
We should be looking at this in the same light
Yes.
that we look at any other disease state.
And I tell doctors now when I train them and consult with them, I said, look at the ages of your people. And I just had a mom recently tell me, I thought she was 45, she told me she was 29. She was just pregnant again. And she had a 16-year-old, and I realized, oh wow, so you were 13 when you had your first baby. But our grandmas we see, they're 42 and they look like they're 70. You know, it's like this accelerated aging. I think that's what everybody needs to kind of start looking at, that, because that's physical evidence that these things matter and they make you sick.
We're up against another break, doctor, but maybe we're talking about why premature death can't be diagnosed at autopsy. It's
that's a good point.
Something to be learned here. We'll be right back after another break.
Together, we can change the news. Find out how at safekids.org.
We're back with Dr. Mark Sloane, the medical director of the Center for Behavioral Pediatrics and the founding member of the Children's Trauma Assessment Center. Dr. Sloane, we know that African Americans suffer disproportionately from higher rates of chronic disease. We've been saying that for years now. But are we missing something in our treatment by not identifying, not assessing, not considering childhood trauma as one of the historical perspectives that relates to the current treatment of the patient?
Well, I think we are, and I think it really crosses all cultural boundaries. I think docs that need to hear that when they're in training, I think that's one of the things that we really feel like medical training, from the very day they start, they should be this kind of, trauma causes you to be ill, and we need to try to mitigate those things. I think that's a major problem.
I am sure that if the ability exists to diagnose it in children, that can be extended to how you actually diagnose other disease states in the adult population of the parents that are associated with this, and what do we need to do to raise all boats in terms of improving the health, no matter where you find it, which is what we're supposed to be doing anyway.
Right.
But here is a lot of untapped thought processes that need to take place. We got to get out of these silos that we continue to exist in.
Love that.
And share this kind of data and this kind of information properly, so that we can get this message out and look forward to the outcomes. We live in a time frame in science and medicine right now that it's outcomes-based medicine. Well, the outcomes are not going to be very good if we can't communicate better than what we're doing now.
We find trauma screening in the adults in the family is really a powerful thing. We wanted to do new CPS cases. We wanted to do trauma screening in all the kids and all the adults in the home, and trauma assessments. And that meaning an impact of how trauma is affecting their life, and then do treatment as a family, and up to 28 hours a week is what we're trying to do, this intensive model to keep the families together. We find that intergenerational link is so not done, and yet the workers, they work together, but they really don't. They're not really designing a model that's helping everybody to function better together.
Right. I mean, a battered spouse in the emergency room
Right.
probably equals traumatic
Oh my gosh.
experiences for children at home. Hands down.
Domestic violence exposure is one of the most powerful one of the most powerful forces on trauma, and it's something that the kids often. It sits with you. It's worrying about being hit or worrying about your mom getting hit is worse than actually watching it. It's worrying about it. That's really what keeps the stress level going high all the time.
Mark, what can the average citizen in the community do when it comes to seeking help in an area like this, either for their children or themselves?
So that's a great question. We've been moving towards a trauma responsive model because trauma informed is what everybody talks about now. That's about knowing about this, but everyone now is telling us, what do we do? The teachers are saying, we know now that I know that I've got to do something differently, but I don't know what it is.
Or a suspected child-parent situation in the emergency room, all of a sudden, social services shows up and sweeps the kids away.
And that's the paranoia from the families, is that you're not really trying to help me, you're trying to take my kids.
Yeah.
And so that's what we were trying to get even the CPS folks to think of themselves as assessment experts and not investigators. Because when a CPS case happens, that's our signal, and so for the average American public person to, like I read about ACEs, I don't know what to do about it. The first thing I think is to talk to your primary care doc about it. And if they don't know, then sometimes you can help them, by teaching them that they should know about it. And I've had some docs say, you know what, I've had a couple of parents that were in my face because I didn't know enough about it. And they shamed me into looking it up. And then I realized I'd missed the boat on this, which I thought was fascinating, because oftentimes we learn from our patients, and we all, I'm sure you say the same thing. And there's lots of resources. We use something called the National Child Traumatic Stress Network. NCTSN.org is a great resource for families. Then you can also, SAMHSA now has a trauma-informed care model. So there's a lot of things out there, but what happens oftentimes is, like you said before, the silos, and a therapist is talking about it, but the teacher doesn't know what they mean, and so the parents lose their momentum, or a family member says, what are you talking about? There's nothing wrong with our family. Our family's fine, because they all have 8 A scores, and that was their normal. And so I think it's important that we look for resources, but then community efforts. And one of the things about ACE initiative in Michigan that we've been trying to do for the last 2 years is to increase awareness in all the segments, and even the business community, when they start going, wait a minute, so the person that gives me the most trouble at the shop has got the highest A score. You see the guy go, oh, really? So the hospital administrator, the vice president that gives him the most trouble has the highest A score. It's like principals have said for years, 10% of the kids give me 90% of the problems. And so all of a sudden, those things are making sense, and pastors are seeing it. And the early child daycare folks are seeing that they can have an impact. So another thing we haven't talked about yet is resiliency building. Resiliency is not automatic, and kids don't get over things because they're young, but we really have to do a community effort to build resiliency in the workforce, in the families, and the child to help, because we really can't look at this as an old-fashioned one diagnosis, one treatment model. We got to build this infrastructure, and it's got to happen now, and it's got to happen as an Amish barn raising. It's everybody's got to do this together and have the same goal.
Right. And we can't keep punting to inadequate community health resources.
Oh my gosh,
that
I love that.
Are a waste of everybody's time,
right,
and a waste of the public dollar.
Right.
It sounds like it's going to take a joint collaborative effort between the medical community, patients, and the community at large to get the legislation done.
Takes a metropolis.
That's right, absolutely. Right, very good. Mark, this has been outstanding. This is definitely a conversation and a topic for our community that has been not talked about enough and is long overdue. Thank you so much for joining us on Primary Care.
Thanks for having me.
We could do this all day.
Yeah, you're right.
Great. Excellent.
Enjoyed
Thank
it.
you so much.
Yep.
Our guest has been Dr. Mark Sloane, Medical Director of the Center for Behavioral Pediatrics and the founding member of the Children's Trauma Assessment Center. I'll be right back with a final thought after this.
Hey Bobo, do trees tell each other stories?
I'm sorry, I'm afraid I don't know that.
Hey, why don't we go find out? Listen.
Do clouds take naps?
I couldn't tell you.
Dad, do stars visit their friends?
Look!
Some final thoughts on childhood trauma. I guess we're not surprised to hear today from our guests that a significant number of problems that adults suffer from are rooted and grounded in their childhood experience. This cannot remain uncovered, not if we are to provide quality-based, evidence-based care to all of our patient population. It's something that we need to uncover. We need to drag it out into the spotlight so that we can focus on it better as a healthcare community and improve the overall health of our patient populations. Thank you for joining us on Primary Care. I'm Dr. Lonnie Joe, and we'll see you next time.